In this video, we briefly review the processes of cardiac depolarization and repolarization. We will focus only on those points most relevant to understanding the ECG readout. We will work mainly with the 2D schematic of the heart shown here. The schematic shows the right and left atria, the right and left ventricles, and the specialized cardiac conducting system seen here in grey. You will remember from anatomy that the main components of the conducting system are the sinoatrial or SA node, situated near the entry of the superior vena cava into the right atrium, and the atrioventricular or AV node leading into the bundle of His, which then divides into the right and left bundle branches in the interventricular septum. During each cardiac cycle, the atria contract in diastole to fill the ventricles, which then contract during systole to supply blood to the lungs and the systemic circulation. Contraction of the atria and ventricles is tightly coordinated by a wave of depolarization spreading through the muscular walls of these chambers. The depolarization wave, seen here in blue, reflects movement of charge across myocyte membranes and is in effect an electrical current spreading through the heart. Following systole, cardiac muscle returns to a resting state, and this is associated with reversal of the movement of charge across the myocyte membranes. This second wave of electrical activity, seen here in red, is termed cardiac repolarization. The leads of the ECG machine are designed to detect and record these two waves of cardiac electrical activity. The depolarization wave spreads through the heart in a highly predictable pattern, and to understand the ECG readout, the pattern of spread of cardiac depolarization needs to be understood. Cardiac depolarization is triggered by an electrical pulse generated in the sinoatrial node. This electrical pulse then spreads through the atria, triggering their contraction late in diastole. The atria and ventricles, however, are separated by a non-conducting fibrous septum. The depolarization wave cannot penetrate this barrier, and in order to activate ventricular contraction, the wave must be transmitted into the ventricles by the specialized cardiac conducting system. In a normal heart, the only route by which the depolarizing wave can enter the ventricular conducting system is through the AV node. In order to allow the ventricles to fill with blood following atrial contraction, the AV node initially delays the spread of the depolarization wave. And after this short delay, the depolarizing signal is transmitted into the ventricles via the bundle of His. The bundle of His lies in the interventricular septum and divides into right and left bundle branches. The right and left bundle branches transmit the depolarizing signal into the muscle mass of the right and left ventricles respectively. We should note at this point that the interventricular septum is the first part of the ventricular muscle mass to depolarize, and it does so by movement of current across the septum from the left towards the right bundle branch. We'll see later that this early left to right movement of current in the septum is crucial to understanding several important ECG abnormalities. As septal depolarization is taking place, the depolarizing wave begins to spread rapidly through the bulk of the left and right ventricles. As you can see here, in the walls of the ventricles, depolarization spreads from the terminal fibers of the conducting system outwards from the endocardium towards the epicardial surface of the heart, and also back along the ventricular wall to the atrioventricular groove. The final piece of muscle to depolarize is the upper part of the interventricular septum, and again this occurs by movement of current from left to right. Cardiac repolarization is not truly propagated between cells. However, cardiac myocytes repolarize at different rates depending on their anatomical location within the heart. Within the ventricular wall, there is a gradient in the rate of cellular repolarization. Cells in the epicardial region have the fastest rate of repolarization and repolarize first following ventricular contraction. The rate of cellular repolarization is then progressively slower as we move from the epicardium towards the endocardium. Therefore, perhaps counterintuitively, repolarization spreads through the ventricles in the opposite direction to the depolarization wave. As illustrated here, repolarization begins in the epicardium and then spreads backwards from the epicardial to the endocardial surface of the ventricles. We'll see later that this retrograde spread of ventricular repolarization is important in understanding the normal ECG readout. We will now go on in video 2 to show you how the depolarization and repolarization waves are analysed to produce the normal ECG readout. We've seen how the cardiac depolarization and repolarization waves spread through the heart. Now we will go on to explain how these electrical events are analysed by the ECG leads to produce the waveforms of the ECG readout. Again, we will work with the 2D schematic of the heart as explained in video 1 of this section. The leads of the ECG machine detect the movement of the cardiac depolarization and repolarization waves as they spread through the atria and ventricles. Leads capable of detecting electrical signal are placed on the patient's body, and the different lead positions record the flow of current through the heart from different perspectives. In this way, the ECG recording can give us information about disease processes affecting different anatomical regions of the organ. We'll see how this works later, but for now we need to understand how the individual ECG leads analyse and record cardiac current. In any ECG lead, the flat line recorded on the readout when no net current is flowing is termed the isoelectric line. It is very important to realise that all of the ECG leads on the ECG machine are set up in such a way that depolarising current moving towards a lead produces a deflection on the ECG paper above the isoelectric line, a positive deflection, while depolarising current moving away from the lead produces a deflection below the isoelectric line, a negative deflection. In contrast, repolarising current has the opposite polarity to depolarising current. Therefore, repolarising current moving towards a lead produces a negative deflection on the paper, while repolarising current moving away from the lead produces a positive deflection. As the depolarisation and repolarisation waves spread over the normal heart in a well-defined and relatively constant pattern, these rules mean that if we know the position of an ECG lead relative to the heart, we can predict the form of readout it records. We'll come back to the nomenclature and position of all 12 leads later, but for now let's see how this works in 2 of the 6 so-called chest leads, V1 and V6. Lead V1 is placed on the anterior surface of the patient's chest in the 4th right intercostal space to the right of the sternum, and therefore to the right of the bulk of the ventricles. In contrast, lead V6 is placed on the patient's chest in the 5th intercostal space, mid-axillary line, and looks at the heart from the left of the ventricles. During each cardiac cycle, atrial contraction is associated with a wave of depolarization spreading over the chambers. As the atria sit at the back of the chest cavity, this wave of depolarization is not only spreading downwards and towards the left from the SA node, but also outwards toward the front of the chest and therefore towards the chest leads. As this depolarizing current is moving towards the leads, it produces a positive deflection on the ECG paper. This is the P wave of atrial depolarization. After a short delay in which no current is flowing, the AV node allows the depolarization signal to travel into the ventricles. As we've seen, the mid-zone of the interventricular septum is the first piece of ventricular muscle to depolarize, and it does so by signals spreading across the septum from the left towards the right bundle branch. This early depolarization signal is moving towards V1 and therefore produces a positive deflection on the ECG paper in the recording from this lead. However, this septal current is moving away from lead V6, producing an initial negative deflection in this lead. As the septum continues to depolarize, the depolarization wave spreads out over the muscle mass of the ventricles. To understand what happens next in the recordings, it is important to realize that the magnitude of the electrical signal generated by depolarizing muscle is directly proportional to the mass of muscle generating it. What this means is that the more muscle present, the more electrical signal generated and the more signal the ECG machine detects. The left ventricle has a much greater muscle mass than the right, and so dominates the electrical signal of ventricular depolarization in all leads. Therefore, as the wave of electrical activity reaches the main muscle mass of the ventricles, the left ventricular signal overwhelms all other signals, and as it is moving away from V1, the deflection produced on the ECG recording from this lead becomes negative. In contrast, however, this signal is moving towards lead V6, producing a strong positive deflection. The flow of depolarizing current around the ventricles is recorded as the QRS complex, and as we've just seen, the morphology of the QRS complex differs predictably in the ECG leads depending on their position relative to the heart. We'll come back to the precise nomenclature of the QRS complex later. When ventricular depolarization is complete, there is a brief period when no current is flowing and the recording returns to the isoelectric line. This period ends with the onset of ventricular repolarization. Remember, repolarizing current has the opposite polarity to the depolarization wave, and therefore when it is moving towards a lead, it produces a negative deflection on the ECG paper and a positive deflection when moving away from a lead. We've already seen that repolarization spreads through the ventricles in the opposite direction to the depolarization wave, beginning in the epicardium and spreading from the epicardial to the endocardial surface of the ventricles. The deflection produced on an ECG by ventricular repolarization is again dominated by the signal from the left ventricle. As this repolarizing current is moving towards V1, the deflection produced is negative in this lead. In contrast, this repolarizing signal is moving away from lead V6, producing a positive deflection. The deflection produced by ventricular repolarization is termed a T wave. Note that the T wave has a very different morphology to the QRS complex. Cardiac repolarization spreads relatively slowly through the muscle mass outside the conducting system. Hence, the T wave is considerably longer in duration and therefore broader on the ECG paper compared to the QRS complex. You should also realize at this point that the fact that repolarizing current moves through the ventricles in the opposite direction to the depolarization wave means that in leads with an overall negative QRS complex, that is, the negative deflection is larger than the positive deflection, the T wave also tends to be negative, lying below the isoelectric line. While in leads with an overall positive QRS complex, the T waves are also positive, lying above the isoelectric line. To use the jargon, in non-diseased hearts, the QRS complexes and T waves tend to be concordant. There are important exceptions to this rule, which we will deal with shortly. Just to tie up a loose end, atrial repolarization produces a relatively weak electrical signal which is buried in the QRS complex and is generally not detectable on a standard 12-lead ECG. In the next video, we will try and ensure that you are familiar with the nomenclature of the ECG recording. understand how the ECG readout in an individual lead is generated, we need to make sure that you are familiar with the nomenclature of this readout. Remember, the deflection produced by atrial depolarization is termed a P wave, while ventricular depolarization produces the QRS complex. The nomenclature of the QRS complex can cause some confusion, but is in fact quite straightforward. Within the QRS complex, any positive deflection, that is, a deflection above the isoelectric line, is termed an R wave. Any negative deflection which follows an R wave is termed an S wave. However, if the first deflection of the QRS complex is negative, this deflection is termed a Q wave. This is important. A Q wave can only exist if and only if the first deflection of the QRS complex is negative. A negative deflection following a positive deflection, no matter how small that positive deflection may be, is an S wave. In lead V1, the classical morphology of the QRS complex is a small R wave followed by a larger S wave, while in lead V6, an initial small negative deflection, a Q wave, is followed by a large R wave. In the example shown here, there is no S wave present in lead V6, although a small S wave is seen in this lead in many normal ECGs. The section of the ECG recording connecting the end of the QRS complex and the beginning of the T wave is termed the ST segment, and the junction between the ST segment and the end of the QRS complex is termed the J point. As all of the ventricular muscle mass is depolarized at this time, there is no flow of current through the heart, and the J point and the ST segment should therefore lie on the isoelectric line. This is generally true, but you will learn later in this course that there are normal ECG variants in which the ST segment lies above the isoelectric line. This becomes very important when we go on to try and identify patients with myocardial infarctions, but that's for later. Finally, the diffuse deflection produced by ventricular repolarization is termed a T wave, and as we've seen in video 2, the T wave tends to be concordant with the preceding QRS complex. We will now go on in video 4 of this section to teach you the position of the leads of a standard 12-lead ECG relative to the heart. Knowledge of these positions will allow you to understand the morphology of the ECG readout and will pay dividends in clinical practice. We've seen how easy it is to predict the form of the ECG readout in two of the chest leads, V1 and V6. If you know the position of each of the 12 leads of the ECG relative to the heart, you can carry out a similar analysis in all 12 leads and build a predicted ECG. Learning the position of the leads of a standard ECG relative to the heart is not as difficult as it sounds, and as we'll see later, pays dividends in clinical practice. Consider the 12 leads in two groups of 6, with the 6 chest leads, also referred to as the precordial leads, examining the heart in the horizontal plane, and a second group of 6 leads which examine the heart in the vertical plane. We will first deal with the horizontal group, the precordial or chest leads. These 6 leads, V1 to V6, are placed on the surface of the chest wall in an arc, from V1 in the fortright intercostal space to the right of the sternum, to lead V2 in the fourth left intercostal space to the left of the sternum, and then at roughly equal intervals to lead V6 in the fifth left intercostal space in the mid-axillary line. These 6 chest leads examine the heart in the horizontal plane. In order to understand their view of cardiac electrical activity, we need to remind you of the position of the heart in the chest cavity. Let's examine a horizontal section of the chest taken at the level of the chest leads. As illustrated in this section through the thorax, the heart is positioned such that the right and left atria sit behind the ventricles at the back of the chest. Furthermore, the organ is rotated towards the left, so that the right ventricle lies anterior to the left, immediately behind the sternum. The 6 chest leads V1 to V6 examine the heart in this horizontal plane. Therefore, V1 and V2 face the anterior surface of the right ventricle. V3 and V4 look at the anterior surface of the left ventricle, while V5 and V6 look at the lateral surface of the left ventricle. Modern machines present the printed ECG readout landscaped on an A4 piece of paper, and the signal from each of the chest leads is recorded on the left-hand side of this A4 ECG readout in numerical order as shown here. The remaining 6 ECG leads we can consider in 2 groups. The standard leads, leads 1, 2 and 3, and the augmented leads, AVR, AVL and AVF. This vertical plane is known in anatomical terms as the frontal plane. To remember the position of all 6 of the vertical leads relative to the heart, use lead 1 as your reference point. Lead 1 looks directly at the heart from the patient's left-hand side and defines 0 degrees in all further discussions of the frontal leads. Lead 2 looks at the heart at an angle 60 degrees further clockwise, while lead 3 is positioned a further 60 degrees clockwise from lead 2. These angles will become important in the next section of this course. The readout from the standard leads, leads 1, 2 and 3, are recorded down the right hand side of the ECG paper as shown here. We are now left with 3 further vertical leads to remember. The augmented leads, AVR, AVL and AVF. AVL looks at the heart from the left, L is for left, but at 30 degrees anti-clockwise, or more to the left if you like, from lead V1. AVR looks at the right side of the heart, R is for right, and just like AVL, it is 30 degrees above the horizontal relative to lead 1. As AVL and AVR are set at 30 degrees off the horizontal plane, you can think of them as the left and right wings or wings of the ECG. AVF looks straight up at the inferior surface of the heart and is therefore at 90 degrees clockwise from lead 1. Think of AVF as looking straight up at the heart from the feet. F is for feet. On the ECG readout, recordings from the augmented leads are positioned between the standard leads and the chest leads, from AVR to AVL, and down to AVF at the foot of the page. Combining our knowledge of the positions of the ECG leads relative to the heart with the simple electrical rules outlined so far, we can generate a predicted normal ECG, and here we have it. A normal 12-lead ECG showing a recording of 2 beats from leads 1, 2 and 3, 2 beats from AVL, AVR and AVF, and 2 beats from each of the chest leads V1 to V6. Note also the long run of recording from lead 2 at the bottom of the readout. This is the rhythm strip, and we will come back to its role shortly. For the experienced practitioner, looking at different areas on this A4 piece of paper is like looking at different anatomical regions of the heart. On this 3D model of the heart, note how 3 of the vertical leads, 2, 3 and AVF, form a group examining the inferior or diaphragmatic surface of the ventricles, a region supplied by the right coronary artery. You will eventually get into the habit of seeing these so-called inferior leads as a single entity in the bottom right-hand corner of the ECG. The chest leads V1 to V4 examine the anterior surface of the ventricles and the septum, a region supplied by the left anterior descending artery, while leads 1, AVL, V5 and V6 examine the left lateral aspect of the left ventricle, a region supplied by the left circumflex artery. In a subsequent section of this course, we'll see the key role these groupings of leads play in diagnosing myocardial infarction and in identifying the vessel obstructed in this condition. There is a lot to try and remember in this video, but as you'll see when we go on to diagnose heart attacks and serious pathology, the perspective of the individual leads on cardiac electrical activity is well worth knowing. We will try and reinforce your knowledge of lead positions in the test material at the end of this section.